rush exam is a three-part examination that begins with evaluation of the pump or cardiac status, continues with part 2, evaluation of the tank, and finishes with part 3, evaluation of the pipes. In this video segment, we're specifically going to focus on part 2, evaluation of the tank. Now this is a three-part evaluation beginning with part 1, evaluation of tank volume, continuing on to part 2, evaluation of tank leakiness, and concluding with part 3, which is evaluation for tank compromise. So in this three-part evaluation, the first part, the evaluation of tank fullness, really means evaluation of the patient's core vascular circuit for volume status or central venous pressure. This can be performed through examination of the inferior vena cava and alternatively with assessment of the internal jugular veins. Part 2, evaluation for tank leakiness and overload, is performed through examination of the extended fast exam, looking for free fluid in the abdominal and pelvic cavities as well as in the thoracic cavity. We can also employ lung ultrasound techniques looking for pulmonary edema or ultrasound bee lines, which can signify tank overload in the appropriate patient. Last, we'll conclude with evaluation for tank compromise, in which we'll again employ lung ultrasound techniques to look for the presence of a pneumothorax. In a hypotensive patient with a positive pneumothorax, this may signify a tension pneumothorax requiring immediate decompression. Here's a slide showing the probe positions for evaluation of the tank. Let's begin by looking at probe position A. This is the best position to evaluate the inferior vena cava, and we can look at the inferior vena cava from the subxiphoid position in both short and long axis views. Probe positions B, C, and D represent the appropriate positioning of the ultrasound probe for investigation of the extended fast exam, in which we can look for free fluid within the abdominal and pelvic cavities, as well as within the thoracic cavities. Finally, probe position E is the positioning of the probe to look anteriorly on the chest for pulmonary edema or ultrasonic bee lines. Now let's learn how to evaluate the inferior vena cava for assessment of central venous pressure. First, I place the probe in the subxiphoid four-chamber position, looking at the heart. Then I rotate the probe more posteriorly down towards the spine to look at the IVC as it runs from the right atrium down through the liver. In this view, the IVC will be seen as a cylinder, allowing us to get the full dimensions of the chamber. The probe can be moved slightly towards the patient's right side to best image the IVC as it runs through the liver. And one would like to follow the IVC all the way down through the liver towards the confluence of the hepatic veins, as the IVC should be measured just distal to this position where the IVC and the hepatic veins join each other. The next step is to visualize the IVC in the long axis configuration to corroborate the findings found on short axis view. To do this, the probe is swiveled with the IVC in sight from the short axis view with the marker dot oriented towards the patient's right to the long axis plane with the probe in an up and down configuration and the marker oriented upwards towards the ceiling. In this way, the IVC will appear as a tubular structure running up and down the screen with the superior aspect towards the left and the inferior aspect towards the right of the screen. In this illustration, we see a long axis configuration of the IVC. To determine the volume of the core vascular circuit or the central venous pressure, the IVC needs to be looked at with regard to two specific variables. The first is the absolute size of the IVC, and the second is the percentage change from expiration to inspiration. The IVC is measured at a point about 2 centimeters distal to the confluence of the right atrium, at a point just inferior to the confluence of the hepatic veins. A small IVC that measures less than 2 centimeters and that collapses greater than 50% with inspiration or a sniff maneuver generally correlates to a lower CVP, less than 10 centimeters of water. Conversely, a larger IVC, greater than 2 centimeters, that collapses less than 50% with inspiration or sniff maneuver correlates to an elevated CVP above 10 centimeters of water. In this way, we can use analysis of the IVC to get valuable information about the patient's central venous pressure. In this video clip, we'll take a look at the IVC in a short axis configuration, first aiming the probe to a subxiphoid four-chamber view right there. We see a positive pericardial effusion. Now let's watch the IVC as it moves inferiorly away from the right atrium through the liver, and we can see there the confluence of the hepatic veins. Remember, we want to measure the absolute size and the inspiratory collapse of the IVC just distal to the hepatic veins. And we can see there that the IVC is relatively small and that it has a high percentage change from expiration to inspiration. We can use M-mode ultrasound to graphically show the changes in the IVC over time. Here we notice that the IVC is 2.74 centimeters at its widest diameter during expiration, but that it closes to 0.44 centimeters during inspiration. And while we talked about the absolute size of the IVC as being a predictor of CVP, I actually think the percentage change during respiratory variation is more important as a predictor of CVP. And in this patient, we notice a greater than 50% change, indicating a relatively low CVP, less than 10 centimeters of water. Now we'll swivel the probe to a long axis configuration with the probe marker up towards the ceiling and the probe aligned in an up and down configuration across the patient's abdomen. Superior to the left, inferior to the right, we see the IVC as a tubular structure. Now, noting the inspiratory changes of the IVC, we can see that the walls almost completely collapse during inspiration. And with a small indicator arrow, I'll show the area where we should generally measure the IVC. That's 2 centimeters distal to the confluence of the IVC to the right atrium, just inferior to the confluence of the hepatic veins with the IVC. So a CVP less than 10 centimeters of water with inspiratory collapse of the IVC. We can again put M-mode ultrasound over the IVC to further graphically determine the general size and respiratory dynamics of the IVC. And we can see that this is a smaller IVC that measures 0.98 at expiration and that almost completely closes, in fact does close during inspiration, demonstrating a low CVP, less than 10 centimeters of water. Let's contrast those last video clips with this one. Beginning with the heart in a subxiphoid 4-chamber view, we see that this heart is not beating well. As we aim the probe more inferiorly down to image the IVC as it moves inferiorly down through the liver, from the right atrium, we can see that this IVC is very large and that it has little inspiratory collapse. In fact, we also see the 3 hepatic veins are very engorged. Notice we can also see little speckles of prethrombus within the IVC, indicating a low flow state. Now we'll put M-mode ultrasound directly over the IVC in the short axis configuration. Notice this IVC is relatively large at 2.52 centimeters and then it has very little change during inspiration. We can also see the speckles of prethrombus within the lumen of the IVC, indicating a low flow state. So this patient has a CVP that's greater than 10 centimeters of water. In fact, this tank is pretty full. Now we'll swivel the probe to the long axis configuration with the probe marker up towards the ceiling and the probe aligned up and down on the patient's abdomen. Superior here is towards the left of the screen and inferior to the right. With a small indicator arrow, I was just showing the engorged hepatic vein entering into the IVC. Recall that we want to measure the IVC just inferior to that point where the hepatic vein enters into the vessel. Here we see very little inspiratory collapse of the IVC, as well as a plethoric or dilated IVC that indicates a high CVP greater than 10 centimeters of water. We can put that M-mode cursor right along the IVC, just it's inferior to the confluence of the hepatic vein. Again, we see the IVC is dilated greater than 2.46 centimeters, but more importantly, notice here the small respiratory variation of the IVC from expiration to inspiration, indicating an elevated CVP greater than 10 centimeters of water. Let's put all that information into play in a real clinical case of a hypotensive patient. This is a 4-chamber subxiphoid view. That's the right atrium, right ventricle, and left atrium. Here we see a large circumferential, dark anechoic pericardial effusion surrounding the heart. So what we'll do is we'll duct the probe inferiorly down towards the spine, looking at the IVC as it moves away from the right atrium into the liver. Here we see the IVC as it emerges from the right atrium. Notice here that this IVC has little respiratory collapse and that it's relatively large in size. And we can see the dilated hepatic veins joining into the IVC. In the presence of a significant pericardial effusion, this is concerning for potential early tamponade physiology as one sees an elevation of the CVP as tamponade progresses. We'll confirm those findings by swiveling the probe to the long axis configuration, superior to the left, inferior to the right. Again, we see the heart with a large pericardial effusion. Notice here we see the IVC that's relatively distended or plethoric, greater than 2 centimeters, just distal to that hepatic vein, and notice the little respiratory collapse of the IVC with inspiration, indicating a relatively high CVP and the potential for early tamponade physiology in this patient. There may be times where visualization of the inferior vena cava can be limited by a gas or fluid-filled intestine or stomach. In these cases, visualization of the internal jugular veins can act as an alternate measure for assessing central venous pressure. In this examination, the head of the bed is placed upwards 30 degrees and the high-frequency linear array probe is placed tangentially or in a short axis view across the internal jugular vein. Here we see a plethoric or distended internal jugular vein that has little inspiratory collapse, indicating a relatively high CVP. This ultrasonic assessment of jugular venous distension, or CVP, can be confirmed by using the probe in a long axis configuration with the probe up and down along the neck in the plane of the internal jugular vein. I like to have the probe marker upwards towards the patient's head, and here we can see the internal jugular vein is distended all the way from low just above the clavicle to high all the way just below the mandible, indicating jugular venous distension on ultrasound or a relatively high central venous pressure. Now let's take a look at the jugular vein in a patient who presented with hypovolemic hypotensive shock. We see here the probe is in a short axis configuration across the internal jugular vein, and we notice a very small IJ vein that almost completely collapses during inspiration, indicating a relatively low CVP and the need for immediate resuscitation with IV fluids. We can corroborate those findings by moving the probe to a long axis configuration with the probe marker up towards the patient's head. We see the carotid artery deep to the internal jugular vein, and we see the closing level of the IJ vein low within the neck, again corroborating a low CVP, less than 10 centimeters of water, and the need for immediate resuscitation with intravenous fluids in this hypovolemic patient. Step 2 in the assessment of the tank is to look for tank leakiness or overload. This is performed by using the extended fast exam, putting the probe into positions 2, 3, and 4, the right upper quadrant, left upper quadrant, and suprapubic views. This will determine the presence of free fluid within the abdominal, pelvic, and thoracic cavities. While the rush exam is not specifically designed for the evaluation of the trauma patient, occasionally a patient may present as a delayed presentation of trauma or after occult trauma with this positive finding. In this situation, a surgical consultation and possible operative repair for an injury to an internal organ may be indicated. In this view, we have a positive right upper quadrant exam with free fluid in Morrison's pouch. Now, in the non-trauma patient, this could indicate failure of the heart, liver, or kidneys as contributing pathology to the patient's physiological state. Now, in the patient with a fever in this finding, this could indicate the possibility of spontaneous bacterial peritonitis and the need for paracentesis to obtain cultures of the fluid. By angling the ultrasound probe above the right upper quadrant and left upper quadrant views, we can actually look above the diaphragm to look for the presence of positive free fluid within the thoracic cavities. Here we have a positive examination from the left upper quadrant view, the small arrow indicating the presence of free fluid within the left thoracic cavity. We can see the spleen to the right or inferior, and we can see the lung waving around superior or towards the left. In the non-trauma patient, this could show the possibility of lung, kidney, or heart failure as an exacerbating condition to the patient's pathology. In the patient with a presentation of occult trauma or a delayed presentation of trauma, this could indicate a hemithorax needing urgent treatment. Lung ultrasound applications have become increasingly important in the assessment of the hypotensive patient or the patient with dyspnea. In this examination, which is still part of Part 2, assessment of the tank, looking for tank leakiness or tank overload, we use the 3 MHz probe to examine the pleura by placing the probe both anteriorly and laterally on the chest. This would be a normal examination, and we can see the pleural line moving back and forth towards the top of the screen. We note here the presence of multiple A lines, those horizontal reverberating lines coming off of the pleura at regular intervals that are indicative of normal lung. In contrast, let's take a look at this video clip taken from a patient who presented with acute pulmonary edema. Here we see the pleural line as taken with a 3 MHz lower frequency probe, and instead of those repeating horizontal lines, the A lines that we saw in normal lung, now we see the development of these vertical lines known as lung rockets. And here we see the lung rockets emanating all the way to the back of the screen using the 3 MHz probe. Lung rockets are also known as ultrasonic bee lines, and these indicate fluid within the alveoli. Now, if the bee lines are seen in multiple areas of the lung bilaterally, this is more consistent with acute pulmonary edema. As pulmonary edema progresses, we can see the development of more and more ultrasonic bee lines, or vertical lung rockets, showing a worsening of the pulmonary edema. In this situation, we almost see a complete lung whiteout, with multiple rays coming off of the pleural line, showing the development of multiple lung rockets within one ultrasound field. Now, while the presence of ultrasonic bee lines are indicative of a syndrome known as alveolar interstitial syndrome, or AIS, which just shows the presence of positive fluid within the alveoli, if this is diffuse on both sides of the chest, this is more indicative of pulmonary edema and the presence of tank overload. The final step in evaluation of the tank is to look for tank compromise, or the presence of a tension pneumothorax requiring emergent decompression. We see the positive lung findings. On the right, with a 10 megahertz probe, we see the lung sliding. As the patient breathes, the lung moves back and forth. We can see the opposed parietal and visceral pleura with positive vertical comet tails and sliding. To the left, we see a positive pneumothorax, and notice here we see the stationary parietal pleura, which shows no sliding back and forth. We also see the absence of the vertical comet tail artifacts. In the hypotensive patient, these findings may necessitate emergent decompression with a needle or a chest tube. So in conclusion, thank you for joining me for Part 2, Assessment of the Tank of the Rush Protocol. As we described, this is a three-part evaluation, beginning with Part 1, Evaluation of Tank Fullness, which, as we described, is an examination of the inferior vena cava and internal jugular veins to assess central venous pressure. Part 2, Evaluation for Tank Leakiness and Overload, is performed by the extended fast exam to look for free fluid within the abdomen pelvis, as well as to look for the presence of ultrasonic bee lines indicative of pulmonary edema. The last part of the tank assessment is to look for tank compromise, or the presence of a tension pneumothorax indicated by the lack of lung sliding and the lack of positive comet tail artifacts. Now we can begin to use the Rush protocol to assist in the evaluation of the hypotensive patient to allow us to figure out which type of shock the patient is suffering from. Let's take a look at this table with regard to beginning with hypovolemic shock to the left. On assessment of the pump, the heart may be small in size and hypercontracting. On evaluation of the tank, the inferior vena cava and internal jugular veins may be small in size with a large percentage change from expiration through to inspiration. In a patient who has an occult trauma or delayed presentation of trauma, we may actually see positive free fluid in the peritoneal cavity or within the pleural cavity indicative of blood. In the second type of shock, cardiogenic, we may see a dilated heart which is hypocontracting. The IVC and internal jugular veins may be distended with a small percentage change from expiration through to inspiration. Also, we may see pulmonary edema, as evidenced by the presence of multiple lung rockets, and it's not uncommon for us to visualize a pleural effusion or ascites in these patients. In the presence of obstructive shock, of which we think of the three main categories being 1, cardiac tamponade, 2, massive pulmonary embolus, and 3, tension pneumothorax, generally on assessment of the pump, we're going to see a hypercontracting heart. In the presence of cardiac tamponade, we're going to look for the presence of pericardial effusion and diastolic collapse of the right ventricle and/or right atrium. Now we'll discuss the findings of a large pulmonary embolus in an upcoming video, but generally we're looking for dilatation of the right side of the heart, and we may be able to visualize a cardiac thrombus. On assessment of the tank and the different types of obstructive shock, we generally will see a distended and large inferior vena cava and internal jugular veins with little respiratory collapse. And in the presence of a tension pneumothorax, we can see absent lung sliding and absent vertical comet tail artifacts, requiring emergent decompression. In the last category of shock, distributive, of which sepsis will be the main cause, on evaluation of the pump, in early sepsis, we'll generally see a hypercontracting heart. As sepsis continues, we may see a component of cardiac failure and hypocontraction. On evaluation of the tank, the IVC and internal jugular veins will generally be small in size with a large comparative change during the respiratory phases. We may be able to see the presence of peritoneal fluid indicating spontaneous bacterial peritonitis, especially in liver patients, and we may also be able to see pleural fluid indicating empyema in the appropriate patients requiring drainage. So now we can see how we can use all of the assessment that we've learned in the evaluation of the pump and the tank to stratify the different types of shock accordingly with the ultrasound findings. So I look forward to seeing you back in the future as the Rust series continues with Part 3, Evaluation of the Pipes.